Please note, today's session is being recorded. If you have any objections, you may disconnect at this time. Thank you very much. On behalf of the National Cancer Institute, I wish to welcome everyone to today's Implementation Science webinar. We are excited to be joined by our speakers, but before we get started, a brief word about logistics. We ask that if you are not already on mute, to please leave your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded, and muting all lines will help us to avoid any background noise. We encourage questions. They can be submitted using the Q&A feature on the right-hand side of your screen. Type your question in the provided Q&A field and hit submit. Feel free to submit your questions at any time during today's call. And with that, I will turn it over to David.
Thank you, Sarah, and thanks to everybody for joining us. You'll see the title is rather law and ordery, a jury of peers, untangling D&I grant reviews with the people who chair them. And we are very grateful to have three of the recent chairs of the NIH Review Committee, DIRH, the Dissemination, Implementation, Research in Health study section that has been around since 2010, and much of that time has been under the expert leadership of our three guests today. And you will see.
Sorry. I was moving slides and apparently no one saw them.
Yes, so.
My apologies. Now you can see all of our wonderful faces.
Now you can see the wonderful faces, the smiling faces of the people who are joining us today.
I apologize.
No worries whatsoever. So you're listening to me right now, and you'll, of course, spend much of the time learning from the expertise and the experience of our three distinguished guests in order as they're listed on this slide. Steve Bertels, who's now at Harvard, at the director of the Mongan Institute, Ross Brownson, who is at WashU, and Melissa Simon, who's at Northwestern. And just a few things to say about each in this particular order. So Steve, I got to know in my former role at the NIMH, and I believe the first time that I got a chance to see him at work, there was an R25 research education grant that was around supporting geriatric mental health researchers who are focusing on both interventions and services. And Steve was one of the real leaders of that field and got so many wonderful folks, not just turned on to mental health services and intervention research, but starting to think about implementation science. Ross I met, I think it was 2004, 2005, and I believe the first thing I ever saw Ross do was an early iteration of this grant review skit that we've done any number of times, and Ross was one of our willing actors and then to get to see him a number of years later, being at the helm in a very serious role at the helm of DIRH was wonderful. And of course, his contributions to implementation science, many folks know, are vast. And then to see Melissa Simon, who I think I first met when she was a reviewer on DIRH, and then to see her go to become the chair for a number of years, incredible expertise around the U.S. Preventive Services Task Force, around really thinking about implementation science and health equity. And she, as well as Steve and Ross, Steve being the current chair, have led the committee with such expertise and such kindness, I think, which has really helped to make sure that each and every one of these applications gets its fair shake and gets the best possible review in the past and now with Steve in the present and the future. So if you haven't joined us, here's a lovely picture of the fireside that we are now pulling ourselves up to. To any of these fireside chats, they really are an opportunity for us to ask whatever questions you want around the topic of our experts, to get them to talk a little bit about their experiences. In this case, really thinking about all aspects of the scientific review process with NIH primarily, and how implementation science studies are understood, are reviewed, are potentially highlighted in terms of strengths and weaknesses by the folks who are in that room. If those of you haven't been in the room of a study section, these are the folks who've really been making sure that the process happens. So the first thing we like to do, and as Sarah had noted and has noted many times, we do have the question and answer box which we'd love to see you start populating. We like to start off with a few questions, but as soon as you start populating that field with questions, we'll automatically turn our attention to those, because our goal through all of this is to make sure that whatever you want to know, we have a chance to discuss. So while you're thinking about those questions, wanted to turn our attention to Melissa and Steve and then Ross in that order. Maybe if each of you could talk a little bit for our audience about how you became interested in implementation science and sort of how you identified this as an area that you wanted to pursue. So Melissa, you want to kick us off?
Sure, thank you, and thank you for those kind words, and thanks everybody for joining today. This is really exciting. So I actually fell into it a little bit because health equity and social justice has been my lifelong mission, and that's why I went into medicine. But implementation science is really where I thought could give the most legs to health equity work, because in the earlier days before I went to medical school, I was in the Chicago Department of Public Health as an epidemiologist, and really just looking at data across community areas in Chicago, I saw programs start and then stop, and then people trying to just put programs into places where they didn't really fit, and they needed to really be thoughtfully adapted, thoughtfully implemented, thoughtfully disseminated, and that was really important for achieving health equity. So I really thought that implementation science is the way to go, and to intersect it with health equity and community partnerships and community engagement. And that's just really excited me, and that's what sparked everything.
Awesome, thanks. Steve?
Some similar parallels here. I guess I was at the time trying to do both a research career while I was also being medical director of an entire state's mental health system. And we were working to implement evidence-based practices that interface at policy, financing, health systems level. And I found that really rewarding because I could actually get some things done and make change. And then at the same time, I was doing R01 studies that were publishing and showing big effect sizes, and then I'd look around and they just weren't being taken up. And so it occurred to me that I was getting impatient with incremental science and wanted to have a high impact, and that this interface between doing good empirical studies and then also thinking about how to pull the levers or think about the strategies or mechanisms that get things into place and sustain and spread was really important to me. I also consulted for years to SAMHSA, Substance Abuse and Mental Health Administration, and saw time and time again things that got funded, and when the funding went away, they died. Also thought that that was a real problem in terms of what we were spending money on. So it became clear to me that I really wanted to move into the implementation area just because of my impatience with conventional science.
Great, thanks. Ross?
Yeah, well, so I guess mine is sort of parallel in ways, but a little different. I'm in public health, and after graduate school, I took a job in a state health department and realized how much of what goes on in a public health agency or interfacing with the governor's office or the state legislature was not evidence-based. So we began to sort of think about the principles of evidence-based public health and what those are. And then, of course, implementation science came along, and that is about how to move those principles into practice in a more systematic way. And a lot of that work started out as learning barriers. And so I've been interested both in sort of the agency part and the policy setting, and then in the intervention work we've done, especially in disadvantaged communities across Missouri. So I think there's some parallels to what Melissa and Steve did, and a few differences as well. But I think I sort of stumbled into it in a way before there was really any name on the wine bottle at that point.
Gotcha. Yeah. So, given that each of you have had different stints at the helm of the DIRH committee, we wanted to see if you might each share your impressions about how you saw or are seeing the field progress during that span of time that you were chairing the review committee. And I think maybe it makes sense to do in the order that each of you have served as chair. So that, from my historical understanding, would be Ross, followed by Melissa, and then Steve. Can you each talk a little bit about how you saw things change over those that time period?
Yeah, I'll be glad to start on that, David. I mean, it's interesting. I was thinking about this. I think in the early days, many times the grants would have to define terms like what is a dissemination study, what is an implementation study. Some of the basic things that the people on the line now would take for granted. So we did a lot more with terminology, explaining the study, bringing in a theory or model that hadn't been really categorized at that point. So over that period, there was really a proliferation of theories and models and sort of bringing them together in health areas and other areas. Across that lifespan, there was also the idea of hybrid design. So the introduction of a hybrid design, is that really a D&I study? If it is, why? If it isn't, why not? And so in the early days, we had to define a lot more around those. And then I think the last piece is probably an expansion to more in different kinds of agencies, more in varied populations and settings, and then increasingly with the focus on transdisciplinary science, bringing in new and different disciplines and the focus that NCI has led in many ways on team science and what that means and how it gets operationalized within a project.
Great. Melissa?
This is Melissa. So yeah, Ross said it really well. I just saw a lot of advancement and innovation in implementation science, and starting to push near the end of my tenure as chair there, starting to push the boundaries with respect to opening it up to other things like de-implementation and sustainment. And I think that's probably where Steve kind of has seen more of. But yeah, I've seen a lot more intersectionality in implementation science, a little bit more with fields, subject areas that haven't had as much implementation science, like OBGYN, for example, things like that.
Cool. Steve?
Yeah, I think what I've seen, and of course I was sitting on the committee previously and have seen it kind of evolve, is that hybrid designs now, which were literally kind of unusual or novel, are now really commonplace. So that's one thing that we're seeing. I think we're seeing increasing sophistication in matching frameworks to study design. Everyone isn't using the same framework. They're adding on a specific kind of nuanced framework, which is, I think, better matched to the design and more theoretically grounded, and some more creativity in kind of designs and novel implementation strategies and topics, so people aren't just doing the same old kind of strategy. I think that we're seeing a little bit more tailoring of implementation strategies, for example, equity-based adaptations, things that are adapted towards special needs groups or underrepresented groups, and then seeing increasingly a bit more kind of electronic applications, digital health, mobile health, interfacing strategies with electronic health records, a little bit of machine learning, and also some more global health kind of issues. So I think people are moving from kind of the basics into, I think, more tailored and really interesting novel applications of both the theory and the strategies that they're testing.
Great, thanks. And just a reminder, as you see this nice fireplace and the lovely beverages in front of them, that you are encouraged, of course, to submit your questions as we go along. But I think as an overarching one, we'll have varied understanding, varied experience with these different review committees, and it might be helpful to hear from you, and maybe Steve, as the current chair, you can kick us off, and then Melissa and Ross can add in where needed. If you might be able to talk a little bit about the review process a bit, and so from your perspective, what applicants should know about the way in which the reviews are conducted that might be helpful as they're thinking about that next set of applications to prepare. Can you walk us through that a little bit?
Yeah, I'll stop off. I mean, I start out, I think some of this is very basic and not necessarily unique to D&I, but I think clearly the number one principle that we all know is that on any study section, you win or lose the reviewer on the first page of the specific aims. So really honing that to perfection is always important. And it's a little more complicated in D&I because you also often have these multi-level or multi-pronged or multi-component interventions that are being tested. So that being really clear, I think that when I think about the applications that do best, I think they're ones that are either extraordinarily targeted and uniquely tailored to a very specific, unique question or population that's novel, or it addresses a question that is respect to the effectiveness of different implementation strategies or approaches for a given problem that has broad applications or implications for implementation science at large. In essence, the second group of grants you look at and say, even if you don't care about or know much about the population, this is incredibly important for the entire field. So either narrowly focused or generalizable. And either way, I think it's really important to kind of tell the reviewers that, you know, that this is how this is going to have really a significant impact beyond your own population area. And then a couple other comments. I think it's really important now increasingly to really be clear about the scientific premise. What's the gap in the science that you're addressing is more and more clear, and that's a directive from NIH. And I think that most of the applications rise or fall as usual on the approach. So being really good at that and making sure it makes sense and is very clear. And then finally, I think we're increasingly seeing that it's really helpful to have somebody on the application that has recognized expertise or which you can demonstrate has expertise in D&I. So coming in entirely without any track record, if you don't have somebody that has some expertise, that kind of gets called out sometimes.
Others want to? Yeah, please.
Yeah, this is Melissa. Yeah, I think Steve articulated it well. Just to piggyback to clarify, scientific premise is not really what it's called. You want the rigor of prior research in that significance section. Don't forget sex is a biological variable in that approach. Don't forget your resource sharing as aligned with the requirements of the specific DI or HPAR. And I support what he said with respect to being clear with frameworks, and the team has to have at least one good recognized implementation scientist, and the approach needs to be solid.
And Ross?
Yeah, I think everything that's been said is accurate. And the one other bit I would add, and I see some of our trainees on the phone, so they've probably heard me say this before, but when we teach people about writing an effective application and about the process itself, is to keep four overarching pieces in mind. One is the audience. Who are you writing for? You're writing for reviewers who may know a lot about what you're trying to write about, or a little. They might be a specialist in your area, but more likely you're going to have people from a variety of different areas. Don't talk to them and explain jargon. Don't belabor things that are obvious, and sort of think about your audience. Think about the context for a reviewer as they go into the review. They'll have a lot of applications. They might be reading this at the end of a long day after the kids have gone to bed. Don't leave things on the table that are sort of boring. Make sure that the thing is, they pick it up and it's interesting and grab their attention. And then you've got the aesthetics. Make sure that the grant, the age page, Steve mentioned how important the age page is. Make sure it's inviting, that the text is not, two solid pages of text in one paragraph. And so people want to read it and it's sort of inviting to the eye. And then the fourth is the organization. Make sure that it all flows from the age page and that the whole thing has a logical flow and it's a story that's engaging that people want to read. And I think sometimes the idea and the methods are very important, but sometimes we forget about some of these sort of broader issues that also can lead to whether your project is funded or not.
Right, so it's a little bit harder. I think it's been a little bit harder to hear, Ross, just the last few things, but from what I heard, it not just the content being incredibly important, but even thinking about how things are laid out on the page. And if one has too dense text, it becomes harder then to really tease apart what the essential components of the application are. Is that a fair retelling of what you were just going through?
It is. That's perfect. And David, I'll try to plug in headphones and see if that will help.
Okay, awesome. So we're starting to get a couple questions, so thanks to those of you who've already sent them in. So I wanted to start with the first one that I see here, which is, recognizing that there are these standard NIH criteria, significance, approach, innovation, environment, and investigator. the investigator team, which is going to come to another, as a check for myself. What are the difficulties and maybe Melissa, you want to start this one, the difficulties in applying those standard NIH criteria to the D&I grants that are coming in? Is there a way in which those are interpreted differently, or how do you consider those standard criteria with respect to these kinds of studies?
I think you can. I'm not sure I really understand the question. Can you reframe it, because I don't find it a problem to be able to take those standard criteria and apply it to implementation science.
So I'll pick up on one. I know that sometimes people have asked us if what I'm focusing on is getting an established intervention to be delivered in different settings, do I get knocked on innovation? Because often people are saying, what's the latest breakthrough in a new treatment or some sort of a new prevention program? And so am I going to be penalized if what I'm really focusing on is spreading, scaling up, sustaining things that have already been discovered? Does that make sense? So people struggle with, what does innovation mean? Yeah.
Mm-hmm.
Okay.
Yeah, I mean, I agree. That's the hardest one. That's the hardest on any application, whether you're doing implementation science or as intervention or something else. I think the important thing is to understand is if you really know your implementation science well and you know your discipline well, you're going to know what the innovation is, because there is innovation in being able to scale, for example, a particular intervention or app or something for or decision aid for a particular new population, and then put a little twist on it, right? You're doing it in this way. You're using this framework. There are ways to actually find innovation, even if you think there is nothing. And that's where it comes back to having the team and having the experts on the team weigh in as well.
Great. And are there other, maybe for Steve or Ross, are there other criteria that sometimes people have a hard time trying to interpret how they might be, framed around D&I?
Yeah, this is Steve. I think people, and Melissa already addressed this, I think people get confused sometimes around the significance issue and think that if they once again tell us how important this public health problem is, that stands on its own feet as being important. And it is, but that's not what's meant by the scientific premise and the way that you're going to actually advance the research. So we take it almost as a given that the thing you're studying has, human importance or public health significance, or at least we normally see that that's easy to defend. Where people sometimes, I think, get tripped up on is are they really advancing a gap in the literature or in the science, or have they done their homework with respect to how this is going to move the field forward? And sometimes also people that are somewhat more, less experienced, see the D&I opportunity as a way to kind of put in place a project or a program that everyone should get because it's like good care. But that's not what the mechanism is. It's about studying something empirically, explaining a hypothesis or testing a hypothesis around advancing the D&I field overall. So, doing something that's good for the population, doing something that addresses an important public health issue is not necessarily science if it doesn't ask and answer a really important question with respect to implementation strategy, methods, or an innovative approach that you're using to get that thing out and scaled or sustained or adapted.
Yeah, this is Melissa. I just want to emphasize that last part that Steve just said. It's got to advance the science of implementation science, or the science of de-implementation, or science of sustainment. That's what you have to ask in order for innovation, because he's right. This isn't a mechanism just to scale a public health program. It's to advance the science. And yes, you can certainly scale a public health program while you're advancing the science, but that's the important key there.
Great. And actually a related question that popped up, and that's the degree to which the review committees consider, and maybe it is related to whether you would see something as advancing the science in terms of the responsiveness to the program announcements. Are the reviewers asked, or are they specifically not, to think about, given that the PARs are supposed to articulate some of the priorities of the field, how applications are either responsive or not particularly responsive, or how do you take that into account in the review, someone wants to know. Anyone want to start with that?
This is Melissa. So we as chairs or as reviewers are not supposed to decide whether or not something's responsive. That's what the SRO does. So by the time it makes it to us as a reviewer and or a chair, we don't discuss whether or not it's responsive to the DIRH PAR.
But what we do is, and I completely agree with Melissa on this, it is the case that when we are in that cluster of grants, which is specifically addressing the DIRH PAR, that we tell people that this is in that cluster. And then when it's not necessarily in that cluster, and they happen to come to our committee because they are implementation science, grants, then we have them in a separate bunch. So I think that it is the case that they are previously pre-sorted and determined, and then we do separately look at these things a little bit differently in terms of, is this clearly in the vein of what the DIRH PAR, if they've said that that's what they are responding to, is it in the vein of that particular announcement, or is it a more generic and general grant proposal?
And I would add to that if it's in that bucket, as Steve mentioned, that is it advancing the method? Is there something new and innovative about this that's going to advance the field? And then always kind of tying it back to the potential impact of this. So if this is successful and it's scaled up, what's the prevented fraction that's out there that could be a population that disparities could be addressed, or where there's a scale-up potential that I think comes into play much more in a D&I grant than it does in an etiologic study or an effectiveness trial.
Gotcha. So a couple of comments you've already made that seem to relate to the expertise of the team, or how you consider the team. And so there are two different questions that I'm going to try and fuse into one. And the overarching question is how the review committee assesses expertise in personnel in D&I. And then there was a related question that was saying that there's a lot said about having an implementation scientist on the research team. And this question of if there aren't a lot of degree programs where the person who's coming out of that degree program has the degree in specifically implementation science, what do you look for in a bio sketch that sort of verifies that they have that expertise? So maybe talking both about the team in general, and then how do you identify the level of expertise in implementation science that seems to be among the team that's coming in for the grant? Maybe we'll start with Ross, and then Melissa, and then Steve.
Sure, yeah. I like to do a grid, basically, where you line up your aims and the methods to accomplish those. And then here are the sorts of skills you need. So if you imagine, there are 9 key skills we need to accomplish, do you have those in the team members? Always remembering that there's sort of the scientific skills, and then there may be skills that are out there in the population. So we work a lot with health departments. So I always have someone from a health department either on as a collaborator, a consultant, or as a paid advisor to the project. So I think that is really essential to thinking about it. As far as the implementation science expertise, I think that one is, you don't have to have a degree in it. You have to have, publications in journals that publish implementation science a lot. You have to have, when you write the statement of your scientific contributions, some of those have to be framed around either methods or content areas in moving evidence to practice and policy. And so there aren't enough degree programs around to say someone has a degree in it, because I don't think any of us on the phone have what we would say is a degree in implementation science, but credible publications and some track record in doing this kind of research that would convince the review committee.
Great. Melissa?
Yeah, I totally agree with Ross. You got to tell the story, bottom line. Grantsmanship is about how clearly you convey the message. So when it comes to the team, you definitely, look, I don't have a degree in implementation science. I don't have a PhD either. I have a master's in public health, and I'm an OBGYN, go figure, with implementation science. So it's important to be able to clearly articulate what your expertise is, and that's the beauty of having that those paragraphs on your personal statement in your bio sketch to articulate that. You can highlight a few publications, again, that you think speak directly to your expertise. And if you don't have a particular expertise, then clearly articulate who on that application is going to help achieve that particular aim, or which team, which people on the application listed are going to achieve which aims. And mapping that out clearly is really important. And then there was another part of that question about how we assemble the study section panel. Again, that goes back to the SRO and his or her magic that they work with respect to pulling reviewers from across disciplines. And sometimes 3 reviewers is not enough for a particular application. Sometimes there's like a disciplinary need where we don't have around the table and need a 4th, like a mail-in reviewer, to help supplement a particular statistical method or a particular disease, or so just something to fill in that need. So the SRO really plays a key role in assembling that team. And then finally, if you have a K award or a R of any form, or an NIH grant, you can start your career early in reviewing and volunteering to be an early career reviewer. If you have several grants and haven't been asked to be a reviewer yet, you can certainly submit your name to CSR, Center for Scientific Review. And those are mechanisms to get you into the pot so that you have a chance actually to improve the pool of implementation scientists or people interested in this science to get onto the review committee.
Right, and so the sort of parallels of the combined expertise and your team is often the combined expertise that's taking a look at the study when it comes in. Steve, anything to add, or should we go? We can go on to another question.
I'd say very little to add. I'd agree with the comments that have been made.
Okay, cool. So a very specific question about, and it was mentioned earlier that you're often seeing, or over time you've seen more hybrid studies. And given that there's papers published that delineate the hybrid type 1, which is more about effectiveness with a little implementation, hybrid type 2, which is sort of split between effectiveness and implementation, and then 3, which really prioritizes implementation with effectiveness a bit secondary, is the level of enthusiasm on the committee, or has it changed over time, similar across all of those types, or do reviewers seem to be favoring or more familiar with certain types versus the others? Anyone want to start with that one?
I'll jump in. I'm not sure that's the right question, and I guess the reason why I'll say that is the method that you use needs to fit the question that you're asking in the stage of the science. Not what are we most likely to be excited about in a way. So I guess what I'd say is that if early on, we just don't know whether something works very well, and you're passionate about wanting to scale it pretty quickly and thinking about it thereafter, but you have a good mixed methodologist or someone who can really kind of help you to observe and document and quantify barriers and facilitators, that's a type 1. And if, on the other hand, you've got, phenomenal evidence, lots of evidence that this thing works, and that's not the problem. There's randomized trials, there's all sorts of stuff, but really the issue of outcomes is really secondary. It's like, how do we get it out there, and what's the best strategy? That's a type 3. And then in between, I think, is the least common one that we see. We're seeing more of these more recently because they're a little hard. There's a bit of tautology that sometimes happens in thinking about how these work. But these things are kind of often, we pretty much know they're pretty much effective, or they pretty much know that they should be implemented. Otherwise, you shouldn't be doing a type 2. And those are a little bit more interesting and complicated, but also methodologically, you really have to be able to defend them. So I think it really is what's the question, and does it fit the stage of science where that particular issue sits.
Uh-huh.
Yeah, I would agree with that. And I think that reviewers generally get a lot more excited about the idea, the potential for the idea, and the execution of that. And the study design that's kind of what you need to execute that study. I think that is not usually what gets people excited about it, unless they select the wrong design for the study question. But I think Steve articulated it very well.
Great. Another question that came in, it'd be great to get your take on this. Should all implementation science applications address health equity in some way? Melissa, do you want to start with that one?
That's a big question. No, I mean, of course, in my heart of hearts, I think there should be an emphasis on what this science advances for populations. And the question is not about health equity. The question is the study that you propose and the science that you propose fit the needs of the populations that you describe in the epidemiology or the significance section, where who is affected the most by the particular issue you're addressing. And so if there is a mismatch, then that's a problem. So you don't want to go saying cardiovascular disease impacts African American at blah, blah, blah rate more than white at blah, blah, blah rate, and then have a study that you're proposing that's all on white patients. I'm making this up, and I'm making an easy example. But that's the point. It's not about health equity should be addressed in every implementation science application. What should be addressed is, does the inclusions that you propose to include and the populations you propose to include or focus on in your particular science match the need and the significance and the rigor of prior research, or the gaps that you identify in the rigor of prior research? Does that all align? So it goes back to what I said before. You really need to tell the story well. That's the grantsmanship. You need to be able to tell that tight story and link every single piece of this application together. Does that make sense, what I'm saying?
Yeah. Anything, Steve or Ross, you want to add?
I would just say that equity and equity-based adaptation is a subset of what we see. So it's an important area, but it is a subset, and I think and if you are going to think about equity as a target, then you really have to think in a disciplined way about, how you execute your design and certainly the strategies, and are you in fact incorporating the end users or whether they're patients or providers or whatever in that design. So what probably is a mistake is if you are thinking about equity, thinking about disparity populations or underserved populations, that you think about and design something in terms of implementation, and nowhere is there any evidence that you've really asked or ascertained or really studied the people that are either in the setting trying to deliver the service, or even more importantly, the recipients of that service. So it needs to be, if you are going to focus on equity, it needs to be a disciplined approach that actually shows that you've done your homework around what it means to pursue that as an outcome or a dependent variable.
Mm-hmm. Great. Ross, anything?
No, I think that's well covered.
Okay, great. So we had a couple of questions that were coming in around career development awards. The more general one being whether DIRH has reviewed and is currently reviewing different K awards. And then there was a more specific one asking for someone who's applying to a K, would a proposal within a single health system be attractive to the DIRH section, and you could even be thinking of multiple levels within that health system. Or I suppose that the counter would be, does it need to cut across multiple health systems? So K awards overall, and then specifically how you might see one that's within a single health system. Anyone want to start?
I can if
Go
you
ahead.
want.
Go ahead, Melissa.
Oh, no, I mean, so I think that absolutely, we review K awards, and I think it's great that you do it. And we don't expect a K award to cover multiple health systems. What we expect is it to be done well. So the point of a K is to launch you to an R and to be an independent investigator, right? So you need to make the case of how, again, telling the story well, how the approach and the science that you propose and that career development that's going to get you to do the science well and learn the science well, propose with respect to your next steps in your future independent research career for implementation science. So it can be within one health system, but what's the question and what's the method you're going to use, and how are you going to learn those in your career development, and who are your mentors going to be to help you with that?
And I'll just comment, I completely agree with Melissa. We don't see as many Ks as I would expect to see, actually. And I'm not sure why that is, whether they go to other study sections or that are within institutes. But it's a small number that we review. I love to look at Ks, and excited by them. But I think, as Melissa said, I think perhaps either there aren't a lot coming in general, or whether or not people feel that it's so big to get involved with systems research and kind of where the unit of analysis or of intervention is a practice or a system that, oh my goodness, I can't quite take that on as a K applicant. I'm not sure, but I think that there's, I think a good K, has all the elements of any good K in terms of the training program, the mentoring, the environment, and having really targeting that your study that you propose tracks back into the skills that you're going to learn and tell us exactly how and where and when and what frequency you're going to learn those key skills that track on in good places. The good news is that there's lots of institutes or summer programs and wonderful things that are out there for trainees now to take advantage of, and I think those can be plugged into these awards fairly nicely and provide some support around what you're focusing on learning.
And the one thing I would add with the second part of that question about the single health system, I agree, a K doesn't need to be done in multiple health systems, but I do think a K always needs to keep in mind where it's leading. A K is usually a pilot study or a feasibility study or a smaller trial. And so will the next trial be done in the same health system? Is that health system different than other health systems? Where will this work lead, and how will it build in the application that follows when the K grows into, let's say, an R01 sort of a thing?
Great, thanks. And you'll see another lovely in the distance fireplace on this one, with wonderful tables and squash, maybe, gourds in front of us.
Orange.
Clove orange is even better. So another question that came up, and I'll take it, it was basically asking the interest of NIH in supporting implementation studies within the VA. And so, historically, each of the institutes, I think, or most of the institutes have had studies that they have supported that take place in VA settings. Often, from the Institute's perspective, we're asking the question of how generalizable is the information? Are the questions being asked? Is the likely application of those findings not just within one specific setting, but within others? And that's kind of a similar question that's often asked, not just VA versus non-VA, but within a particular health system that may not look as much like others. Investigators are often able to successfully argue how the phenomena extend beyond just this one particular system. And that's usually at least where we've seen people be successful. It's in saying, while we have the opportunity to study it in this environment, the findings and the questions being asked, the people and the way in which care is being delivered or services are being delivered has analogs elsewhere. So that's at least how, from the NIH perspective, we see that sort of VA or any particular situation. I do want to ask a similar question that came up down here, but is not necessarily in reference to health systems within the U.S., but this issue of how the review committees think about work that takes place outside of the U.S. And so questions about how relevant the project, if it's in a global space, needs to be for U.S. populations, and recognizing that low and middle income countries, for example, may be very different. Is it hard, or how do people try and make the methods, the approach, the study relevant to the U.S.? Anyone want to just reflect on how you see the international applications coming in?
Yeah, this is Ross. I'll take a quick go at that. I think that at least at the time when I was on DIRH and then chaired it, people looked at the importance of addressing health equity no matter where it occurs. So I think the study section was often very receptive to international applications. And so is there something new and novel that we can learn about delivering a new service, a new clinical process in a disadvantaged low resource setting? And then for some populations, so I've seen this, for example, for Latin American countries, let's say a study being done in Mexico, what we learn in Mexico will benefit the high percentage of Mexican Americans who are living in the United States. And so sort of cultural things that might be in one country that transfer to another country, mainly to the U.S. We had a cross-country study funded here that crossed China, Brazil, Australia, and the U.S., and we got very little pushback about why are you doing this in other countries. So I think that now program staff may have other reasons where how they sell it, but I think for the review group, they're looking for what we'll learn about addressing health equity and how might it apply in other countries, including in the U.S.
Great. Other thoughts?
Yeah, I think, we see a fair amount of global health or other country applications, and I think Ross put it very well. What doesn't work is if you say there's never been a study of, collaborative care in China. Well, there's probably never been one in Ecuador. I mean, who knows? But that's not good enough. So the question is, what's the science that's been done? How are you going to use this as a laboratory that's actually going to explicate or illustrate a really important fundamental question in implementation science? I think that's probably the most important metric. I think how it translates back and how it back translates into the U.S., I have to say I don't hear a lot of people bring that up and worry about it. I think it's obvious. I think if anything, it's like, how does this laboratory, how does this opportunity that may be not fettered by fee-for-service, kind of financing, or that is so underserved or so underrepresented in terms of professionals that you must use lay health workers or indigenous community providers? And could that possibly, if it works, in the end of your presentation, at the end of that specific aims, it may apply to very rural areas in the United States or other countries that don't have professionals. So I think it's about the science, and then it's about, yes, some implication backward, but it's really about how you're asking a unique question. It's not unique just to say there's never been one study like this in this country or this region of the globe. That is not a justification.
Yeah, no, I agree. I don't think I have much to add. Again, I hate to keep saying it, but it is how you tell the story and the why and weave it all the way through. And there's absolute merit in actually looking at something that is working in the developing world or a low and middle income country and trying to test it and adapt it here in the United States. So, I mean, it works both ways.
Great. So another question, just more generally, as you reflect on the applications that you see, maybe each of you can say what the most common mistake that you see that people may make in their applications that you'd just love to share so that nobody ever makes it again. Melissa, you want to start us off?
Just one.
Oh my gosh. I can't just say one. Tell the story. Don't forget all the components of your application. Like if you have letters of support and you forget to upload them and you refer to them in your application, don't do that. Don't forget all the components of human subjects, including timeline. Take time to actually do the human subjects well, because if your application requires human subjects and it's clinical trial, do them well, because those count in your score. And they count during the actual discussion period of the review process, and they can pull you down. And don't forget sex is a biological variable. I'll stop. I'll let Steve and Ross add.
That was a good one in like 6 or 7 parts, but that's awesome. Steve?
Make sure that you really convince us that what you're proposing is feasible. So sometimes, the lack of pilot data that really illustrates feasibility is a killer for R01s often. And sometimes being extremely ambitious. I've never heard anyone say this is underly ambitious. So it's got to be feasible. You got to have some pilot data. You need to kind of think carefully about it. And then I think having applications that again haven't done their homework in terms of showing what the gap in the literature is. And then one that often comes up too is interdependent aims, where if aim 1 doesn't work, aim 2 is kind of irrelevant. So be thoughtful about that and think through the logic of the way that you're asking the questions that you are.
Great. Ross?
Yeah, well, I think I have 5, but I think they overlap. So I was kind of thinking about this. So I think the first is this syndrome I call the airdrop model syndrome. That someone has a model, they drop it in somewhere in the application, but it doesn't carry through all the rest of the application. So make sure that the model you use is carried through all the way from the aim stage to the analysis and dissemination. Another is a half-baked idea, an idea that is not all the way there, that isn't going to be a sellable idea, that isn't something new and different that will move the field forward. A third is, I think Steve alluded to this, the lack of pilot data, especially for larger R01 grants. Reviewers are generally risk averse, and so they want to really be able to say that if we award a large R01 grant, that this is going to have a good chance of being able to be carried out. Another one, I think, the fourth one is the lack of buy-in from stakeholders and partners. That this kind of gets the idea of good letters of support, people on your team who understand the practice and the policy setting in which you're working. And then the fifth is kind of basic, but I think it's sloppy writing and sloppy organization. I think reviewers equate sloppy writing with sloppy research. So make the writing really tight, make it organized well, make it easy to read, and so that when they read it, they not only think this is a great idea, it can be executed, but this is really a pleasure to read this application. And I think that always helps your chances.
Great. Wow. So lots of, collectively, I think, a lot of good advice for folks. So we only have a couple of minutes left, and I did want to see if each of you, because we have folks who are listening in who are at different stages of their career, some cases people who are early career investigators, in other cases we have mentors who are often asked to support their early career investigators. And wondered if each of you might just offer your advice for early career investigators who are thinking of moving more into implementation science. What would you suggest would pave their way more gracefully and smoothly? Melissa, you want to start us off?
Don't give up. Again, it behooves you to start an application early, whether it's for a K or an R, so that you can get lots of good feedback and editing. And you want that feedback to be given to you by people who are tired. Because again, we read applications, as it was mentioned earlier, when we're tired. And so they need to be really clear and tell a story that's very connected. But definitely don't give up. This field is amazing. There's still so much opportunity, and that whole comment about innovation earlier, there is a lot of innovation still to be had in D&I, and there's just so much opportunity. So this is a great field, and I look forward to reviewing more applications in it.
Great. Steve?
Yeah, I would say several things that are perhaps, I agree with Melissa entirely, that maybe a little different area that is, I think first of all, find a mentor that really has some grasp of this literature and the area. So mentoring is just so critical because this is complicated. This is messy science, and we love the mess. I mean, those of us who seek out implementation science, systems research, are not the same people that like to work in petri dishes and move one cell forward or back in terms of some sort of genetic material. So you have to have people that are thoughtful or experienced that are mentoring you. That's one thing. There are now a host, largely due to the wonderful work by David and others. There's just all these wonderful workshops that exist, institutes that 1 week boot camps that you can go to that are sponsored by different institutes. The D&I meeting in December is fabulous, and every year just gets better and better. There's also CIRC, SIRC, which is also another meeting to think about. And there's lots of also web-based materials now that you can access that have wonderful talks and lectures. So it's not the case that this is kind of a secret society and you have to kind of figure out a way to get in. If anything, the access to wonderful educational materials, wonderful boot camps or workshops that you can get trained in that are competitive, yes, but terrific if you get to go to them. And then the various meetings that have sprung up are really terrific. Also, read the Bible, the Bronson, Coldix, Proctor, translating science into practice, dissemination, implementation, research, and health book. So there's just a host of things you can take advantage to get into this, and I agree that it's just an exciting and terrific field, and just be persistent and you'll succeed.
Great, Ross?
Yeah, I know we're just about up on time. I'll be quick. I think that the one Steve mentioned on mentoring, also think of mentors who do different things. So someone who might have great technical skills in an analytic area might be different than someone who can help you negotiate the work-life balance a little better. So don't think of, I have to have just one mentor who can do everything, but you might have 4 or 5 key mentors that can really help you find your path forward for someone early career. I think this idea of teams and finding teams that are both skillful, but people you really enjoy working with that make your work fun, because it's a great, fun, exciting field. For early career, have your grants reviewed by others, do mock reviews, have it reviewed maybe a couple, 3 times before it ever goes into the NIH officially, so that it keeps improving, so that you've got that practice and you keep improving it before it gets to the DIRH or other study sections. And then the last one's a baseball one. Think about what is a great baseball player, a hitter has a short memory at the plate. And I think always think about, if your grant doesn't get discussed, it's okay. All of us have had occupations that don't get discussed. Dust off, learn from it, know that it's not a perfect process, but if you have a good idea and you stick with it, in the end you can get it funded and your work can make a difference. And so I think that's a message all 3 of us have brought forward today that I think is also really important.
Great. So we started and ended with don't give up, keep going, and shake it off, I guess, if need be, and keep working. So thanks to the 3 of you. I'm going to turn it over to Sarah to close us out.
Thank you so much. And so I'm going to echo my thanks to Melissa, Steve, and Ross for today's session, and to remind folks on the phone that this is actually the cherry on top, let's say. I don't know. It is the end, the conclusion of our trilogy, yes, our 3 series funding-focused webinars. And so we also want to take a moment to thank Melinda, Beth, and Sangini from our first K Award or Early Career Investigator Award session, and then also Mega, Becca, and Ted for sharing their sample grants with us and talking us through that process. So these 3 together sort of give you a really wonderful picture and some insight into implementation science and funding here at NCI. And so I will thank all of those folks again. Thanks, David, for his time and for your attendance and great questions today. And with that, your feedback is important to us, and we encourage you to complete our online evaluation. A link to the survey will open a new window once this session has concluded. An archive of today's session will be made available shortly on our website, and we hope to see you at another fireside chat or campfire chat in 2020. Thank you so much. You may disconnect at this time.
Okay, thanks, everyone.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye.
David, Steve, Melissa, Sarah, if you hear me, great job. I think you all did an awesome job.